Hello everyone. Now I'll be discussing question on cardiology. So we have a 66-year-old gentleman. He's a known case of ischemic cardiomyopathy, and he come to you due to 2-week history of progressive shortness of breath and non-productive cough. 1 week ago, he was instructed to increase his dose of furosemide, but it did not help. He had no chest pain or orthopnea, and at present he had a MI 5 years ago, has severe left ventricle systolic dysfunction, ejection fraction of 20% only. He has an automatic implantable cardiovascular defibrillator AICD. 6 months ago he was hospitalized with recurrent AICD shock due to ventricular tachycardia, and this was successfully treated with antiarrhythmic therapy. Okay. At present, he is afebrile, BP is normal, and pulse is normal. Membranes are moist, that means there is no dehydration. JVP are flat. Okay. And when he is seated, that means again a point goes that he is not having congestive heart failure at the moment. But bilateral inspiratory crackles are there. No cardiac murmur, no edema also. There are 2 points which are really against the diagnosis of CHF. Bilateral lung infiltrate, middle lungs field are there. Well, we are getting a mixed picture. Let us see what is there. Most likely cause the patient problem is antiarrhythmic toxicity. Why this? Why not others? Well, as we have seen the patient clinical presentation is consistent with amiodarone-induced interstitial pneumonitis. Well, if you go through the question again, patient was started with antiarrhythmic drug 6 months ago, and before that he was being given repeated shocks. That means he was having ventricular arrhythmias, and he was treated successfully with the antiarrhythmic therapy, and the therapy is continued. And definitely one a common drug that we use in such situation is amiodarone. But amiodarone itself has got a lot of toxicities. It's not a very safe drug. There are toxicities. For example, at least regarding the lungs, which I said, interstitial pneumonitis. And what are the points in favoring progressive dyspnea, non-productive cough, bilateral inspiratory crackle, and the chest radiographic finding? They're all going in favor of interstitial pneumonitis. And chest X-ray, localized or diffuse or ground glass opacities, which can be migratory also. Pulmonary, if you do the pulmonary function test, classically it leads to type of restrictive lung disease. And definitely in such cases, the diffusion capacity for CO will be reduced, DL, CO. Well, in fact, reduced diffusion capacity is a feature of all restrictive lung disease. It is normal. This diffusion is normal in obstructive airway disease. But there is one exception. Stop the video, write down the answer in your copy. Tell me in which obstructive airway disease the diffusion capacity is reduced. Well, the right answer is emphysema. Okay. Well, now let's talk about amiodarone. It is a class 3 antiarrhythmic drug, and it is used for management of arrhythmias, especially ventricular arrhythmias. especially in coronary artery disease and ischemic cardiomyopathies. It can cause severe potential adverse effect, and we need to monitor so many parameters. For example, TSH, because it can lead to both hypo and hypothyroid. So there are many other things to be monitored also in this patient. Now, as a question is on the pulmonary toxicity. So, what are the pulmonary toxicity which can occur in these when we are giving amiodarone? Interstitial pneumonitis, usually within months of therapy. Our patient was started 6 months ago. That means within a few months only we could detect it. There can be organizing pneumonias. Sometimes it can come as a acute respiratory distress syndrome, although uncommon, but or diffuse alveolar hemorrhage. Pulmonary nodule or solitary masses can also be there, but they are all uncommon. This is the most common pulmonary side effect of amiodarone. Now look into this. Amiodarone-induced interstitial pneumonitis. You can see lovely label picture is there for your better understanding of subject. Now let's look into other option. This is the very close option in the differential diagnosis. Okay, well, why this cannot be? Flat JVP. JVP is normal, it's not raised. Although the patient has ejection fraction of 20%, but still we can JVP not raised. That is, the point goes against congestive heart failure. Absence of peripheral edema. These two are very, very important finding to diagnose any case of congestive heart failure. And moreover, he was given higher dose of diuretic, but there are no improvement. So these 2 points, that means the patient is, although has heart failure, but still is not a decompensated state, but definitely these points are going against the diagnosis of congestive heart failure. Dietic toxicity. Well, this can lead to intravascular depletion, and there will be signs of dehydration. The mucous membrane should be dry. Okay, when we are dehydration, but in our patient mucous membrane is wet, so this already automatically rules out. Moreover, when dietic toxicity will be there will be electrolyte imbalance, particularly hypokalemia, hypomagnesemia. They are very important finding when we are using furu, and they very commonly use diuretic in congestive heart failure, but that lead to profound hypokalemia and hypomagnesemia. These findings, they lead to themselves can lead to many problems. So this is ruled out. And bilateral, and moreover bilateral and this electrolyte imbalance will lead to palpitation, and bilateral infiltration is not expected with diuretic therapy. Tricuspid valve insufficiency, we expect holosystolic murmur, so-called pan-systolic murmur in the left lower sternum. There will be signs of right heart failure like prominent jugular veins, hepatomegaly, and peripheral edema. But as I told you, they are all JVP not raised, peripheral edema is not there. So this finding is ruled out. And now there are, again, stop the video, write down the answer. I have got few more lovely questions for you. What is a special finding in liver palpation in a case of tricuspid regurgitation? I told you, hepatomegaly occurs in tricuspid regurgitation. But if you palpate, what is the special finding you have, and what is the JVP? Which wave in JVP is very prominent in tricuspid regurgitation, also called insufficiency? Stop the video, write down the answer of these 2 questions. Well, when we palpate, classically you get pulsatile liver. With every heartbeat, you can see pulsation in the liver. And which wave? V wave is very, very prominent in these patients. Okay. Now let's look into option E, viral pneumonitis is one of the differential diagnosis, but interstitial pneumonitis is more likely. The reason being lack of fever. Patient is afebrile. Usually in case of pneumonitis, we expect fever to be there. Time course of symptom after initiation. Because 6 months ago the patient was started on antiarrhythmic drug. Okay, and viral pneumonia doesn't last for 6 months. Radiographic bilateral lung infiltrate involving primarily the middle lung fields. They are again not a finding that we go in case of viral pneumonitis. But this is a very, very important point. This doesn't last for such a long time, 6 months. So, golden line to remember, major side effect of amiodarone. It can be cardiac, it could be bradycardia, it could be heart blocks. Pulmonary, most common is chronic interstitial pneumonitis. Endocrine, hypo and hypothyroid, very, very important. Regarding GIT or hepatitis can occur. Even there can be transient elevation of transaminase also. Ocular corneal microdeposit and optic neuropathy. This is again a very commonly asked question. Dermatology, blue-gray skin discoloration, you can see typically, lovely picture, and there can be peripheral neuropathy. Okay, so they are all the side effects of amiodarone therapy. Thank you very much.